Hi everyone. Today we are here to discuss on the posterior urethral wall, which is a most common condition of the males and has an incidence of 1 in 8,000 to 25,000 and is the most common cause of end-stage renal disease and renal transplantation in children. Posterior urethral wall has a familial predisposition. It affects the short arm of chromosome 11, which undergoes partial duplication, affecting the molecular markers, that is, increasing the ACE2 gene expression and decreasing the ATR gene, causing renal dysplasia. Embryologically, it appears as early as at the age of 8 weeks after the development of the posterior urethra from the urogenital sinus. Scientists who played a major role in the discovery, evolution of treatment are as follows. Morgagni and Langenbach discovered it in autopsy of the fetus in 1717 and 1806. Then, in 1870, Tolmatschew described it as the congenital posterior urethral obstruction. Young, in 1919, coined the term posterior urethral wall. Randall, in 1920, did the first endoscopic resection, and 1995, Divan named the term copum, which means congenital obstructing posterior urethral membrane. The posterior urethral wall presents in three forms anatomically and is classified as the Young classification matrix, in which type 1, the most common, occurring in 95% cases, is the standard type, and in which the mucosa grows from the peromontanum to the external sphincter and is also known as the sphincter sail deformity. The second is rare and causes much clinical symptoms, is the growth of the mucosa from peromontanum to the neck bladder. The third, which occurs in 5 to 10% cases, is a ring type, also known as a wind-sock deformity, in which the urogenital membrane persists as a ring even after the division of the cloacal membrane. Now we are here to discuss about the cascade of obstruction, that is the high pressure effect and the pulmonary hyperplasia. The changes: bladder undergoes the following morphological changes, that is the smooth muscle hypertrophy, extracellular matrix deposition, altered blood flow, and the poor contractility. These are all because of the molecular drivers from COX2 causing micturition reflex disruption, TIMP, TGF beta causing fibrosis, parathyroid hormone related pain causing detrusor relaxin. They all have an impact on the renal and upper tract, which causes an initial spike in blood flow, glomerular filtration rate, followed by dramatic crash, which lead to tubular damage, leading to failure of renal concentration ability, fibrosis of the pelvis and the parenchyma. These all in turn affect the pulmonary cascade, which lead to decreased fetal urine production, causing oligohydramnios, which in turn causes the pulmonary hypoplasia and facial deformity. The pulmonary driver is the main perinatal mortality reason. The bladder tries to relieve the pressure built in by four mechanisms. The first is the VURD syndrome, vesicoureteric renal dysplasia, in which one of the kidneys takes up the extravasated urine into it and undergoes hydronephrosis, and the functioning of one kidney is preserved while the other undergoes dysplasia. In the second, the bladder or the renal system ruptures, causing leak of urine into abdominal cavity, causing urinary ascites. The third, the bladder wall herniates, absorbing massive volume of fluid, forming bladder wall diverticulum. And in the fourth condition, the urachus becomes patent, reopening of the bladder into the urachus again. Systemic damage caused by the posterior urethral wall. The lungs undergo pulmonary hypoplasia, kidneys they undergo reversible glomerular changes or the irreversible dysplastic changes. The tubules lose their ability to limit sodium and water loss. Bladder loses its sensation and becomes incontinent. Ureters lose their ability to contract and transport urine. The condition can be diagnosed antenatally by the use of ultrasound of the fetus, in which we can have the keyhole deformity noted with the distended bladder and the posterior urethra. It can be diagnosed as early as 12 weeks of gestation. The other changes noted are of the hydroamnios, oligohydramnios, and hydroureteronephrosis. The dysplastic changes of the kidney noted are the increased cortical echogenicity, loss of CMD, and cyst proliferation. The prognostic markers of the amniotic fluid at 22 to 30 weeks help us plan the way of surgery. They are the sodium chloride osmolarity and the beta-2 macroglobulin levels. In the immediate postnatal period, the neonate presents with the assessment of the triad of renal damage, pulmonary hypoplasia, and the bladder emptying status. The clinical signs are of that of the pulmonary hypoplasia, decreased urine dribbling or thin stream with palpable abdomen distension. The systemic crisis present as the refusal to feeds, failure to thrive, electrolyte imbalance, vomiting, convulsions, urinary retention, and severe UTI. In adolescent group, they present with diurnal enuresis, recurrent unexplained UTIs, chronic urinary stream, episodic urinary retention. The gold standard investigation for posterior urethral wall is the voiding cystourethrogram, in which the bladder wall appears thickened, highly trabeculated, with visible divertically. The upper tracts show the vesico-urethral reflex. The bladder neck appears hypertrophied. The urethra are grossly dilated. And the obstruction, the abrupt transition at the exact site of the valve can be noted. But the preliminary condition to perform the investigation is that the urine culture should be negative to prevent endotoxemia. The latest modality of investigation is the contrast enhanced ultrasonography, which is emerging to avoid radiation exposure of the neonate. Coming to the intervention modalities, antenatally, if diagnosed less than 20 weeks, medical termination of the pregnancy is planned. If diagnosed during the period of 20 to 30 weeks, serial vesicocentesis, fetal cystoscope, or vesicoamniotic shunts are planned for. In more than 32 weeks, we proceed for the early delivery. The immediate postnatal management comprises of the bladder decompression by catheter, double J stunt, suprapubic catheter incision or cystostomy, and administration of prophylactic antibiotics. Resuscitative measures should be taken up, correcting the fluid loss and the fluid electrolyte imbalance. And if there is severe pulmonary hypoplasia, ventilation of the neonate needs to be considered. And in the investigation protocol, USG is done within 48 hours of antenatally detected cases. Urine is sent for culture and sensitivity, and renal function tests are also performed in 72 hours. The surgical execution is done by primary endoscopic valve ablation by the use of a cystoscope of size 6 to 8 French with a working channel, and can be done in neonates weighing less than 2 kg. For resection of the valve, 9 French cold knife hook or laser with Bugby molar monopolar electrode are used. Irrigation is done using 1.5% isoglycine. Incisions to the valve are given at 5, 7, 12 o'clock position. The superficial bladder neck incision is added if detrusor hypertrophy is present. Post-ablation, imperatives pause. Temporary diversion allows critical bladder cycling, ensures the posterior bladder wall is taut to prevent prolapse, and a mandatory circumcision is strongly advised as it reduces the risk of UTI, which occurs in 50 to 60% of the cases. The post-surgical complications include the acute post-op complications of bleeding, incomplete valve resection, iatrogenic urethral stricture, and injury to the external sphincter. There are persistent upper tract alteration like the bladder neck hypertrophy and poor bladder compliance, concomitant vesicoureteric junction or pelvic-ureteric junction obstruction, reflexes obstructing megaureter, the floppy ureter, dysplastic ureters that remain dilated due to poor muscle tone and even with strictly non-obstructed, ongoing tubular damage. The bimodal morbidity peak, in which there are two peaks, the first peak appearing at the neonatal age because of the pulmonary hypoplasia and severe renal dysplasia. The second occurs in childhood or adolescence because of the back pressure, repeated UTIs, and wall bladder dysfunction. Long-time surveillance or follow-up is required to optimize renal function, minimize UTI, prevent scarring, and achieve urinary continence. The first way the follow-up is done is by blood chemistry and urine analysis, ultrasound of the KUB, and uroflowmetry, DMSA scan after 3 months, and video urodynamics at 5 to 15 years of age. Pharmacologically, anticholinergics are used for bladder dysfunction, alpha blockers for bladder neck hypertrophy, and for emptying of the bladder, clean intermittent catheterization or Mitrofanoff procedure are done. Pertinent changes occur in the urinary bladder which lead to progressive worsening of the obstructive uropathy despite successful resection of the posterior urethral wall, and is termed the wall bladder syndrome, which is characterized by a triad of polyuria, bladder insensitivity, and post-void residue, which is incomplete emptying, leading to non-compliance, severe incompetence, and hydroureteronephrosis, causing the end-stage renal disease. The urodynamics of the wall bladder syndrome is age-related paradox. In early childhood panel and infancy, there is detrusor hyperreflexia, and in adolescence, there is hypocontractility and atony. In infancy, anticholinergics are used for treatment, and in adolescence, anticholinergics are strictly contraindicated in the treatment part. The end-stage management is by preventing myogenic failure, the threat of the SNOB, syndrome of nocturnal overdistension of bladder, causing polyuria combined with bladder insensitivity, massive overnight stretching. The left unchecked, this causes complete irreversible myogenic failure and recurrent severe UTIs. The intervention is done by implementation of an indwelling catheter for overnight bladder drainage, which provides a crucial 7 to 10 hour period of continuous decompression, acting as an essential adjunct to preserve bladder muscle tone. Pelvic floor muscle training must be encouraged in such patients. That's all for the posterior urethral wall. Thank you.